And we're ready to get. Good morning, everyone. We're ready to get started. Sierra Tucson and Skyland Trail are pleased to partner to bring you this webinar today. Thank you so much for taking time out of your busy schedules to join us. My name is Julie Dukowski, and I'm one of the National Referral Relations Representatives at Skyland Trail. Before we get started, I'd like to tell you a little bit about our programs at Skyland. We are located in Atlanta, and we specialize in treating adolescents and adults who have a primary psychiatric diagnosis. We do this through a full continuum of care, including residential, day treatment, and IOP services. For adults, we also offer transitional living as well as independence coaching. Our specialty evidence-based therapies or evidence-based recovery teams for adults include CBT, intensive DBT, first episode psychosis and cognition, as well as social integration. Dual diagnosis is offered as a co-area of focus for individuals who are in recovery from a substance use disorder. We also have an adolescent program that opened just under 2 years ago. We treat adolescents who are ages 14 to 17. And we recently updated and implemented a new therapeutic model that includes tracks in CBT and DBT, as well as ecological systems theory groups. Skyland Trail is in network with several private health insurance companies. And as a nonprofit, we also offer need-based financial assistance for families to help them cover costs. Now it's my pleasure to turn it over to you, Joy.
Thank you so much, Julie. My name is Joy Sebekindu, and I'm a licensed professional counselor and one of the treatment placement specialists based out of Atlanta, Georgia. For those of you who may be unfamiliar with my team, I am one of nearly 60 individuals strategically placed throughout the country, and we provide complementary navigation through the behavioral health system, supporting individuals, families, and providers with residential treatment recommendations for those who may be struggling with substance use, eating disorders, trauma, PTSD, and other primary mental health concerns. We really pride ourselves on our ability to provide vetted resources that may be both inside and outside of Acadia's network of facilities. You will be receiving a follow-up email after this presentation with more information on our services and how to get in touch with your local TPS. We are so honored to be co-hosting today's event with Skyland Trail, who has been one of our trusted resources for our team, as well as Sierra Tucson. Sierra Tucson is one of Acadia Healthcare's premier residential treatment facilities for substance use, pain recovery, and behavioral health located in Tucson, Arizona. Before I introduce Dr. Chotwal, who will be kicking off today's presentation, there's a couple of housekeeping items I want to go over. In the interest of time, we really want to kind of scoot through our presentation, but we will leave time for Q&A. So that we don't miss any questions that we want to address, please use the Q&A feature instead of the chat. We certainly will be monitoring the chat throughout the presentation, but again, we want to make sure that Dr. Chotwal and Dr. Hunter have an organized way to see your questions. As we mentioned in our advertisement, we have a couple of raffle items, and following the webinar, we will be hosting a follow-up coffee chat with Dr. Hunter and Dr. Chotwal. Right before this webinar started, we randomly selected the following people: Ellen Ashler, Bill Williams, Valerie Van Dam, Dion Smith, Brooke Rollins, Dana Palmquist, Elizabeth Coleman, and Debbie Donovan. We will be sending information on how to access the exclusive coffee chat webinar room. However, if any of you are not in attendance and or are unable to join us from 1 to 1:30 p.m. Eastern, please let me know so that we can allow another person to join in that opportunity. We certainly have other rifle items that we will be announcing at the end. But in the interest of time, I want to go ahead and introduce Dr. Chotwal. Jocelyn Chotwal has been an integral part of the medical staff at Sierra Tucson since 2008, serving as the director of the MOVE program and associate medical director before being named chief medical officer in January of 2020. As CMO, Dr. Chotwal is responsible for managing the medical department, as well as overseeing the integrative care team and applied neuroscience department. As she will demonstrate throughout her presentation, she strives to ensure consistent, high-quality patient care through the optimization of internal processes that help increase provider face time with patients. In addition, Dr. Chotwal leads the facility's mental health education outreach effort at national and international conferences and seminars to promote the importance of integrative care for successful, sustainable recovery. Without further ado, I certainly want to thank you so much, Dr. Chotwal, for joining us today, and take it away.
Thank you so much, Joy. And good morning, good afternoon, everybody, wherever you're joining. It's 8 o'clock my time because I'm in Pacific Standard Time. So I think we'll move into the afternoon during my presentation. If you're having any difficulty viewing the presentation, please feel free to let the organizers know in the chat, but I'm hoping that this is going to be shared adequately. So I'll be talking about treatment-resistant depression, which is where we start off this morning. And I'll be sort of laying the groundwork for Dr. Hunter to come and talk about TMS options, but really hoping to bring home the point about why we need to be talking about treatment-resistant depression. And I do not have any financial disclosures other than the fact that I am employed by Sierra Tucson. And it is, in terms of our objectives, we'll look at depression, we'll talk about treatment-resistant depression especially, which is our topic today. We'll understand the challenges inherent to treatment of TRD and review the current evidence-based as well as consensus-based treatments for TRD. So the reason that not everything falls under the evidence-based bucket is that treatment-resistant depression can be sort of a place where people find themselves slowly slipping into, and at that point being able to do really focused treatments or assessments and doing RCTs or randomized controlled trials with that population can sometimes become hard. So there can be just things that experts agree on, which is consensus-based, that we'll be talking about, and I'll try to highlight those areas as we go along. And then we'll talk about novel as well as experimental approaches for difficult to treat depression. And some of my own personal objectives when I'm presenting. My own personal philosophy is one that I call intentional evolution. And my belief is that all of us are changing at every moment of every day. So every interaction we have, every time we are talking to somebody, you're attending a presentation, you're doing any kind of work, you are gradually changing. And we know that even from brain chemistry and understanding of neurobiology, that we all have something called neuroplasticity. So every interaction we have, everything we do changes our brain a little bit and hence changes us a little bit. And through that personal philosophy of intentional evolution, I want to make sure that in today's presentation, we work at reducing stigma around mental health. We increase awareness about especially treatment-resistant depression, since that's our topic. And then also that we build community and connection, really identifying who are other people who are in that same area of work with us, who are other people who have those same shared beliefs about continuously growing and evolving and improving themselves. And so starting with that, we'll go with a very quick overview of major depressive disorder as it is presented in DSM-5. So it typically, you need to be having depressed mood, or your client, patient, the individual you're working with. And then also we typically notice with major depressive disorder that there can also be a markedly diminished interest or pleasure in all or almost all activities. So that's also called anhedonia. And so you either need to have depressed mood or anhedonia, and then have all these other symptoms which are presented below. And these are typically supposed to be present in a 2-week period at least. And oftentimes for me as a psychiatrist, by the time I see people, they've had way more than 2 weeks of symptoms. And with individuals that I'm working with longitudinally, when I used to do outpatient practice, that was the thing that I was often looking at in regular follow-up appointments to see if they started slipping back down into a major depressive episode. Because the quicker we catch something like that, the quicker we can start moving towards treatment or changing medications and therapeutic approaches. Other depressive disorders in DSM-5 include disruptive mood dysregulation. There can be persistent depressive disorder. I don't know why I mentioned MDD twice in my slide. There's also premenstrual dysphoric disorder, substance or medication-induced depressive disorder, and then an unspecified depressive disorder. All of these differ in duration, timing, presumed etiology. We will not be talking about anything other than major depressive disorder today because some of these have different etiologies and have different ways of treating or approaching it, and it's too broad for today's presentation. Looking at the continuum of mood disorders, I am a mood disorder specialist as I consider myself, and so going from the spectrum of mania all the way till severe depression, we also noticed that previously this is how we classified it. We thought depression was on one side and mania, hypomania, etc. were on the other side of the spectrum. What we do notice now is that over the last decade or so, there's been greater and greater understanding of the mixed features which can be present both in a depressive disorder as well as in somebody with bipolar disorder. So if you are treating somebody who typically only has dealt with depression, you may still see some of those manic, hypomanic features in their presentation. And that doesn't often mean that they just have bipolar disorder because they have a few symptoms. It can really mean that they could be having a mixed episode, even within the greater context of just having a major depressive disorder. So those would be some of the things to really keep in mind if you're a clinician, and if you are somebody who themselves struggles with depression and you're listening in, then these are some things you want to ask your doctor as you're working with them. So treatment-resistant depression, our topic of today. So the definition that's most agreed upon is failure to achieve remission with 2 or more adequate antidepressant trials. I want to highlight that word adequate, of different classes. So they can't be 2 medications that are both SSRIs. They can't be 2 that are both SNRIs. You have to have 2 different classes of medications that somebody should have tried within the current depressive episode. So this time when the person is depressed, we want to be really getting detailed history about that. And we know from a lot of studies done in psychiatry that about half to 2/3 of patients only respond to antidepressant treatment, which means that we're not even talking about remission at this point. We're just saying, hey, I had a little bit of a response. And half to 2/3 is not a great number, because that means at least 1/3 to about half are not. And then majority of people who do receive treatment with medication, psychotherapy, neurostimulation, etc., that is guideline-based, still do not really achieve full remission, which means they always have some residual symptoms of depression. They're not fully free of the dysfunction that it can cause. So why do we care? People who have TRD typically are more symptomatic, so they tend to spend more of their time being depressed rather than not being depressed. And they also have a harder time getting to that point of remission where they're free of symptoms and can really go back to living a full life. So that's really the reason identifying treatment-resistant depression and getting to work on it for me as a psychiatrist becomes very, very important, because I want to know that as soon as my patient is even moving towards treatment resistance, I want to start working with them more intensively, calling them for appointments more frequently. If they're in our treatment center, then we're trying to stack up more treatments. And often we notice people only come to residential treatment once they're already in a treatment-resistant type of phase. And so that's a lot of the people that we're treating. These are also individuals who are more likely to attempt suicide. And then the reason I keep on talking about remission is that once you achieve remission in depression, you really do increase the chances of recovery from major depressive disorder. And for those of us who are clinicians, and especially for psychiatrists, it's really pushed to us in residency that the minute you start noticing that a person's failed one medication, 2, and once they've had a second depressive episode, the likelihood that they'll have a third and a fourth depressive episode increases to such a degree that after somebody's had more than 2 depressive episodes, we're asking them to stay on medication lifelong. And so those are really some of the things that I keep in mind when I'm working with individuals. One of the ways that you can classify treatment-resistant depression is through the Thase and Rush staging model. It can be a good way to communicate with other colleagues and really understand what stage of treatment resistance somebody is at. And you'll have these slides available so you can go into it a little bit deeper, but a lot of the treatments that are mentioned in these stages are things we will discuss, even though a little bit briefly over the next few slides. And factors that add to treatment resistance can be in the biological category, psychological category, genetic, and personality. These are categories I created really to just help organize the material. These are not something that you'll just go find in a book somewhere, but hopefully they're also classifying them that way. And so with biological treatment resistance factors, there can be neurotransmitter dysfunction. This is something that's talked about ad nauseum. However, we've also started noticing that that's not the only thing that contributes to depression and mental health issues. So how people used to say, oh, I have a chemical imbalance, that's really an overly simplified way of thinking about depression. We now also know that the HPA axis can have a disturbance, which is your the hormonal pathway that essentially works within your stress response also. Then we also know that people can have dysfunctional circuits, so neuroanatomic circuits in the brain. There can also be abnormal neural activity in certain parts of the brain. We might hear more about that in the TMS talk. And then also we noticed that there is activation of the inflammatory system. So I'm an integratively trained psychiatrist, and within our integrative medicine practice or integrative psychiatry practice, we really do look at that and see how people who have other inflammatory conditions really have a higher likelihood of being depressed as well. Psychological features that are noticed is somebody who has depression with melancholic features is more likely to have treatment resistance. If they have frequent and repeated episodes, if they previously did not achieve remission, as we spoke before, psychiatric comorbidities, so something like an anxious depression, or if they have other conditions like OCD, et cetera, that they're dealing with, that can make it harder to treat, even addiction for that matter. And then also if they have a high frequency of stressful life events or trauma. So the small t, you can just add it up, or the big T trauma. Genetic factors, there have been polymorphisms in the HTT, which is the serotonin promoter region, that have been noticed that typically also correlate with more difficult to treat depression. And then there are some interactions between BDNF, which is brain-derived neurotrophic factor, and NTRK2 polymorphisms, which are again really paths that neuroplasticity in the brain can be affected. So your brain's ability to respond and change. So even in context of treatment and psychotherapy, sometimes it can be harder for those individuals to have that same amount of change. And then finally, there have been some personality factors that have also been identified relating to treatment resistance. So there being personality disorders, especially high neuroticism, which is a trait, psychological trait. And then also when people have low extroversion, openness, or conscientiousness, that can also really add to treatment resistance. And finally, if they have high levels of social inhibition. Those are recent studies done out and share when they're distressed can typically have better outcomes in depression treatment. So that high levels of social inhibition kind of showed up in that study as well. So what can we do about treatment resistance? I'm also getting a slight message that my internet connection was unstable. So if you missed something, just ask that later in the Q&A. And the way I approach treatment resistance is by something I call the tiramisu approach. And in prior presentations, I've sometimes shared that I have a secret love for tiramisu. And now I guess it's not as secret, but it's still there. And what the tiramisu approach really is it's a holistic layered approach, just like the dessert. And like it has so many different yummy things that go into making a tiramisu. What we're trying to do in this treatment approach is we're trying to use all different types of treatment modalities. I'm not just going to use medications. Dr. Hunter is not just going to use neurostimulation. We're going to use everything we've got, all the tools in our toolbox. We're going to use all of them for treatment resistance. And our goals are symptom remission, enhancing overall well-being, preventing future episodes, as well as the most important thing, which is improving quality of life. What's the point of no symptoms if your quality of life doesn't improve? And so as part of this tiramisu approach, we use psychotherapy, psychopharmacology, nutraceuticals, CAM therapies, and then also neurotherapeutics, which falls under that category of neurostimulation. And so we'll go through each of these 5 categories today. I know that I have limited time and I can talk about this topic ad nauseum. So I'll rush through some things, but I'll also give you my email. So some basic principles, which anybody who's a clinician in the group already knows about. We want to conduct a biopsychosocial assessment, get collateral, formulate a really steady diagnosis, differential diagnoses, and typically the golden rule with differential diagnoses is keep it fairly broad so that you really do address everything that could be going on. Establish a therapeutic alliance, educate, help the patient with self-management, develop collaborative goals, do a comprehensive management plan, use evidence-based treatments, monitor outcomes. Outcomes are really important because we can all be biased in the way we look at a patient. We're like, I think you're doing better. But we really don't, if we don't have the data to prove that somebody is doing better, then it's really hard to say that. So using measurement-based care and monitoring outcomes has really become the gold standard in psychiatry at this time. And so using this tiramisu approach, we'll go on to discuss psychotherapy. Various types of psychotherapeutic approaches that can be used for treatment-resistant depression. These are all different types of psychotherapeutic modalities that do have evidence for use in depression. Specific ones that you may want to consider using in treatment-resistant depression, we'll talk about in a little bit. But you typically want to identify patients for psychotherapy by noting that they're not having a psychotic episode, and typically also that it's not a melancholic depression, because in melancholic depression, these are the patients who are not getting out of bed, not really engaging with you. So starting with psychotherapy is just not typically effective. You want to also make sure that you're using psychotherapy in conjunction with pharmacotherapy when you're doing that for treatment-resistant depression. You want to look at patient preference in terms of what type of psychotherapeutic modality you use. And then one of the psychotherapeutic modalities that has the greatest evidence is cognitive behavioral therapy. And so cognitive behavior therapy is also the one with the greatest evidence in treatment-resistant depression. One reason is it's easier to study and do RCTs for, but it's also very structured and hence sometimes easier to study from that perspective as well. And as we know, it's very effective. This study, it was a review and meta-analysis published in 2018. It included 6 RCTs, which had almost 900 patients. They used CBT, MBCBT, which is mindfulness-based cognitive therapy, and then rumination-focused CBT, as well as smartphone CBT. So those are all the different forms that were used. And even though mindfulness-based cognitive therapy doesn't clearly say CBT, it is a form of CBT. In this study, they noticed after they did the intervention that patients who were diagnosed with treatment-resistant depression typically had greater efficacy when they were using CBT. And they also noticed that 73 out of 174 CBT subjects actually showed response. And when we looked at remission, 45 out of 174 CBT subjects actually showed remission, which was greater than the control population and almost a 50% increase in efficacy by use of CBT versus just using normal care without really a structured CBT intervention within that. And then they followed these patients 6 months post-intervention, as well as a year post-intervention. And even at those 6 month and 1 year timeframes, we noticed that there was a higher response rate and also higher remission rate. And as you know, response is good, but remission is obviously better. And even though there was a small number of people who actually remitted, 45 out of the 174, we do notice that that's a better number than the total in the control population, which seemed to be even half of that. So at least adding CBT to regular treatment for treatment-resistant depression seemed to have improved outcomes overall. This is some of the data if you want to look at it in more detail. But as you notice, it does have a positive association overall. Sorry, there we go. And then there was also another study for acceptance and commitment therapy for treatment-resistant depression. This was out of Australia and New Zealand. They did a manualized ACT intervention within a group setting. It was a very small study. However, in terms of including the patients, these were people who had treatment refractory mood as well as anxiety disorders. They did 4 weekly sessions. Each of them were done by licensed psychologists. And then they did an acceptance and action questionnaire at the end, as well as a self-compassion scale. In the small study, they did notice that there was a paired sample t-test passion scale, as well as the other scale that was used. We noticed that there were overall improvements both in self-kindness, so right here, and then also self-judgment, which were positive, and then also common humanity, mindfulness, and the overall, there was a positive association as well. And then especially this was useful in individuals who had comorbid medical conditions. So when they separated out the data, even within those 19 individuals, it seemed like they were the ones who benefited the most. Another study on treatment-resistant depression with trauma-focused psychotherapies. This one used EMDR as well as trauma-focused CBT. So you see CBT kind of coming in again. These individuals were already getting pharmacological treatment. So typically most TRD studies, you won't see them only use one intervention. It's typically done with regular treatment and then they add on an intervention because it's unethical to leave those patients without any treatment. And then the results in this showed that there was reduced depression symptomatology. There's about 50% of those treated with trauma-focused CBT actually had remission, and 75% treated with EMDR. This is a population that I feel extremely passionate about because we do know that when individuals have early life trauma or that they have ongoing difficulties with their living environment where they have that small t trauma that gets added up, that recovering from pain symptoms, recovering from depression can become increasingly difficult. And so if we can find something that really works for these patients, if you can do regular treatment for depression and layer on a trauma-focused psychotherapy, it seems like identifying these patients becomes really important. The individuals who were identified in this study did do a detailed history and know that they had a prior history of trauma. It wasn't just anybody was given trauma-focused therapy. That was part of the way that they selected candidates for the study. And so overall, when you look at all the studies that are done in TRD, which are quite a few, but again, multiple small ones like the ones we discussed, you have to make sure that there are some shorter term goals along with longer term goals that you identify for treatment, because these are patients who typically will lose steam when they don't see remission. And so it's very hard to keep them engaged in treatment. It's also important to provide psychoeducation to help them understand why you're taking the approach you're taking and what type of improvements they can really expect. And then also you want to take a more active role. So sometimes we as psychiatrists tend to take, a role, especially in psychotherapy, where we're letting the patient guide the treatment and sort of bring what comes to them. But in this, that's why CBT is seen to be more effective, because you want to move more into that coaching and slightly more directive role, giving them homework and assignments, because otherwise they won't really be able to stay engaged. And we typically use shorter sessions, and then, like I was saying earlier, use some homework assignments and constantly do a reappraisal with the patient about how much progress they think they're making, because often with depression, they have a negative bias, so they don't see what you're seeing. And also you may start noticing some behavioral improvements, but they may not notice a mood improvement. And that's one of the areas to stay focused on. The next category is psychopharmacology. And we'll move through this a little bit quickly too, as we know the world is all about popping pills sometimes. Multiple categories of antidepressants. Clinicians are aware: SSRIs, SNRIs. There's another called NDRIs, and all of these are really based on the type of a receptor profile that they're working on. And then we also notice some other types of medications that are not clearly identified as antidepressants that can be used, which are some of the atypical antipsychotics, ketamine, stimulants, and then here I've also put triiodothyronine, which is T3, which is a thyroid hormone, and then lithium, which is a mood stabilizer. These are well-known adjunctive agents to use. One of the studies that really put us on this path of discovering what the way was to layer medication treatments and do that in a stepwise manner was the STAR-D study. So this is an older study that many people may have already heard about. In this, they had over 4,000 patients, all adults, in which they tried to start with citalopram, which was a well-known antidepressant at the time. And then they started to see that when people would not respond appropriately to that, they could either add another medication, they could switch from citalopram, or they could add psychotherapy. And what was noticed after doing that is then again, they would assess who had response, who did not. And then the next step was adding either lithium or T3, which is that thyroid hormone, or they could switch to mirtazapine, which is an antidepressant, and nortriptyline, which is a TCA antidepressant. And then the fourth step was they could then switch them to an MAOI, which is a monoamine oxidase inhibitor, or venlafaxine, which is an SNRI, or mirtazapine. And these are all stepwise things that they did. And the reason to do that was that this is how psychiatrists practiced. So this was one of the first times that they were studying just how we practice rather than pulling a set of people aside and giving them medications and interventions in sort of a closed bubble type of setting. And what we noticed was that in the very first step, only about 33% of people had response. And when they had to move to that second step of adding switching or therapy, then it was about 25% more. And then when you added a third step, there was a few more. Fourth step, few more. And overall, by doing this sort of layered approach and quickly moving and changing treatment approach, about 70% of people could reach remission. And this is really important for us as psychiatrists to remember, because sometimes you can feel like, oh, let's give this medication a little bit more time, whereas really what we notice is that about the 2 to 4 week mark, if the person's not having some response, there can be the recommendation to then switch or add a different agent and really essentially change your approach. The major takeaway was that people, again, who reach remission function better and relapse less. So that always has to be the goal for us as psychiatrists when we're treating. Another study that was important was the international study to predict optimized treatments in depression, or the I-SPOT-D. This was a biomarker study, so they were trying to assess what type of biomarkers can sort of guide us in major depressive disorder treatment. There's over 2,000 patients. In this also, they used different medications, and they noticed that the outcomes were essentially the same with all the different medications. But what they noticed in the I-SPOT-D, and I haven't gone into detail because it's just a really complex study to look at, but the takeaway message for today's presentation is that depression with anxiety is harder to treat. And the more severe the depression is, the harder it is to take it to remission. And so I think that's where catching it early, not really going towards letting it go towards treatment resistance, is one of the important things. And then again, I think for the TMS talk, that depression with anxiety would be good to remember, because TMS can be a treatment modality that can be helpful in that. There's multiple evidence-based treatments that can be used for different types of depression when it comes to medications. And I've listed them on the screen, but we're not going to go into detail right now about those. And then strategies, especially looking at psychopharmacology for treatment-resistant depression. You can add a second antidepressant with a different mechanism of action. You can add an atypical antipsychotic. These are FDA approved, at least some of them. Then you can add lithium, T3 or buspirone, which are adjunctive. So you can't take away the antidepressant, but this can be something that can be added. And then also psychostimulants. These have to be done with really careful assessment of the person's eating status, sleeping status, and their overall physical health before these can be considered. So, again, it's not a easy thing to just do, but you want to work with your doctor to assess that. And then finally, a class of glutaminergic medications. So these are things like ketamine, which is becoming used more and more. And now there's also the intranasal ketamine, which can be used, though working with insurance on that can be a bit of a battle. And then some other studies that I had put in my slides, but I know may be hard for us to fully address given the time. This was a study for using ketamine in treatment-resistant major depression. Again, a smaller study with about 72 patients. They did one IV infusion and they compared it to midazolam, which is essentially also an anesthetic agent like ketamine has been prior to using it for depression treatment. And what they did was they used patients who had a history of 3 or more antidepressant trials that they had failed. And what they noticed in this study was that individuals who were using, here we go, midazolam, which is the little orange triangles, did also have a little bit of a response, which maybe speaks a little bit to the placebo effect. And so we noticed that there was some improvement here, but the patients with ketamine, which is the red squares, actually had a greater improvement, which was statistically significant. And what we also noticed was that that improvement actually carried forth all the way till day 7. And then when they also did further studies in a different sample, we noticed that individuals who got that ketamine, the improvement continued to persist beyond those 7 days. And here, when you notice the same data in a different way, you notice that with midazolam, there was a drop in depression ratings, but the improvement with ketamine was much higher. The response rate was about over 60%, whereas here we're lingering a little bit below 30%. And as you go to about day 7, patients with ketamine still had over 40% improvement, whereas those with midazolam dropped even below 20%. And then another double-blind, randomized, placebo-controlled study for ketamine in treatment-resistant depression. This also had, less than 70 people. They had received either intravenous ketamine or a placebo, and they were trying to test if ketamine was more effective if it was given 2 times a week or 3 times a week. And this was really important because we need to determine treatment frequency. And as this was looked at, they assessed something called a MADRS score, which is a depression rating scale. And in this also, ketamine clearly separated away from placebo with a greater drop in the MADRS score. That was actually noticed all the way through the 2-week mark here. And this one on the left is with the twice-weekly dosing, the one on the right with the 3 times a week dosing. And as you notice, the difference isn't marked even in these slides, and it was also not statistically significant. So it was noted that you could do 2 times or 3 times a week. And there are now some studies that are coming out that show that glutaminergic toxicity can occur if you go too frequently. So it may be something that doing it about 2 times a week and continuing to address response can be important. And then there are some anti-inflammatory based immune treatments or immune-based treatments that one can use. There were some studies on anti-inflammatories in treating treatment-resistant depression because of that anti-inflammatory or inflammatory I guess, where the inflammatory pathway gets involved in depression. And they tried to do some open and controlled studies. One was using celecoxib, which is another type of non-steroidal anti-inflammatory. And then they also used TNF-alpha, infliximab, which also is an immune modulator. Most of these studies were very small. This one study I thought was a little bit more robust and you could maybe do something with it. Clinically, this one noticed that if you got a CRP, which is an inflammatory marker, if you assessed that pre-treatment and you looked at it, if somebody had a higher concentration of that inflammatory marker, and then they were given infliximab, which is that immune modulator, they actually had greater response versus placebo. However, if their CRP concentration was lesser and was not significant, then actually infliximab worsened their depression. And this study is really important because sometimes people just say, oh, well, you know, inflammation contributes to depression, so maybe I should just prescribe my patients an anti-inflammatory. And this study tells us that no, it's really not that simple. It's a very complex topic. It's not really ready for clinical prime time right now. And so we need to be studying it a little bit more and really assessing safe ways of using these treatments. I typically try to recommend something like curcumin, which is the active ingredient in turmeric for patients. But again, there too, now, since looking at the study, I've been a little bit more careful because maybe that could also have a negative effect. So I think we really need to wait till this can become prime time clinical use information. And then next category is nutraceuticals, or food that can be medicine. There are various nutraceuticals that have been studied in depression. None of these are used only for treatment-resistant depression. Most of these studies just show that adjunctively, when these are used, they can be more beneficial in depression. And for some of these, we actually recommend doing blood levels. So something like folate, vitamin D, iron, zinc, you can actually do a serum or blood level and assess if somebody would really benefit from these. When it comes to SAMe, studies show that efficacy and safety is equivalent to conventional antidepressants. It's probably also safe in pregnancy. However, in terms of using it clinically, you always want to make sure it's a company that gives it in blister packs or some way that it's not exposed to air. You could take SAMe or prescribe it with folate and B12, because usually it needs some active cofactors to have the positive effects in the brain. And those are really two cofactors that are important to use. It can be a little bit expensive for some patients, but its dose has a fairly wide range, so that safety piece at least comes into play for this. Another one is omega-3 fatty acids, which a lot of people seem to use. There's multiple studies that actually show that this is effective in depression and can also be used in bipolar depression. Again, just for all these nutraceuticals, they're adjunctive. When it comes to the dose range for omega-3 fatty acids, there's again somewhat of a broad range, but the big thing you always want to look when you're looking at formulations of omega-3 fatty acids is that they should have more EPA, which is a form of omega-3s, versus DHA, and so the ratio should be over 3:2, and 3:2 is kind of that ideal ratio. So when you're looking at formulations, that's what you want to be looking for. And you usually want to treat for anywhere between 1 to 4 months to assess efficacy and to see if it really will be helpful for a person. It is also one of those things that reduces inflammation in the body, so some benefit in that way as well. Then folate. We usually talk about folate when it comes to pregnancy. That's really like the big place that it's used. And so folate is something that is also water soluble. So if you take too much of folate, you'll essentially excrete it out. It's nothing to be extremely worried about. The studies that were done always used it as an adjunct to antidepressant, and they were small samples. But what they did show was that L-methylfolate, which is that active form of folate, did seem to have greater positive effects, and especially for people who have the 5-MTHFR polymorphism, which some of the genetic tests that can be done nowadays show. And then again, they recommend adjunctive use in TRD, especially if you have low folate levels, but also if they're somewhat suboptimal and you're not having good response to an antidepressant. There's the consideration that maybe you don't have adequate amount of nutritional cofactors that could be helpful in improving response to the antidepressant. Then vitamin D. This is one of my favorites because in Arizona, people think they would always have a high vitamin D level since it's synthesized from the sun. And it's amazing with the amount of sunscreen people use and how much they hide from the sun. People in Arizona are extremely deficient. And so I think we shouldn't just think that because a place is sunny, somebody wouldn't have a vitamin D deficiency. There has been some studies which show that it could be responsible for the seasonal pattern. And even though we don't really notice an impact once you add vitamin D to improvements in mood, what has been noticed is that if you are able to optimize somebody's vitamin D level, they tend to have a lower likelihood of having another depressive episode. So it doesn't go down to 0, but it may increase the time between episodes and make it so that the current depression or the next depressive episode is a little bit further out. The ideal level for vitamin D is debated hotly. When you look at a vitamin D level per the lab, so any of the SonoraQuest, LabCorp, et cetera, whichever company one is using, they tend to have a fairly low level as their normal level, sometimes closer to 30 or 20 to 30. However, in depression circles and in mental health, we recommend anywhere between 50 to 75 because that's seen to be the place where that benefit for reducing the next depressive episode comes. And then you also don't really go into that risk area where it might increase the risk of kidney stones, etc. A maintenance dose is 2,000 international units. Obviously, if somebody's deficient, we need to go higher than that. The thing with vitamin D is it is not water soluble, so you can get toxic in vitamin D. So these are not candy to be, quickly consumed. You want to be very careful. You want to let your doctor know and help them monitor your levels with you. Then iron and zinc. Iron typically recommended to only be supplemented in a deficiency. You can check ferritin levels, especially important for vegetarian vegans, which has been me for the last few years. So I'm actually going tomorrow to get lab tests myself. And then postpartum ferritin levels are also seen to be important to check because they can't predict postpartum depression or the likelihood of postpartum depression. So it could be something that one could really address more acutely. And then zinc, again, if somebody's deficient, it can increase the risk that they may not have a full remission from depression. So if somebody is having difficulty getting significant improvement in depressive symptoms, that might be something you test for. Okay, I'm going to look at the time. I know I'm rushing through because I want to give Dr. Hunter all the time that he needs. So CAM therapies, next category. In CAM therapies, which are complementary and alternative, we also call them integrative therapies now. There can be light therapy, exercise, yay, yoga, acupuncture. And again, with these, similar to the nutraceuticals, these are only adjunctive. Like we were talking right in the beginning with treatment-resistant depression, you want to add everything you can. So anybody who's identified as treatment-resistant depression should have medication, psychotherapy, and then everything else is essentially being layered on. Looking at light therapy, there's multiple studies. Some of them are not very high quality, some of them are better. One of the better studies was an 8-week randomized controlled trial with 122 patients. In that, they actually exposed the patients to about 30 minutes a day of 10,000 lux fluorescent light. Lux is a measure of light energy. And so when you go on Amazon or some other website and you look for light therapy, they give you all kinds of boxes. They start at something around $20 and go into hundreds to thousands of dollars sometimes. And it's really important to get a high quality fluorescent light box if you're going to use this therapeutically. If you're just using light in the morning because where you live is dark or you don't have a lot of windows in your space and you're using that to wake up, that's great. There's a lot of nice studies in sleep that show that if you have morning exposure to light before 9 a.m. It helps really set your circadian rhythm. But if you're using it for depression, you want to work with your physician and make sure you're using a high quality fluorescent light box. There are apparatusi. They are available from places like Lowe's and Home Depot and these stores where you can actually go measure the lux of the light box that you buy. And if you're really going to commit to use this in treatment, that might be something to consider. In this study, they actually did light alone. They did it in combination with fluoxetine, which is an antidepressant. They compared it with fluoxetine alone and then placebo. And what we noticed is that the combination of fluoxetine, which is an antidepressant, and light had the greatest response. Light alone, interestingly, had more response than fluoxetine alone. However, again, because this was a shorter study, about 8 weeks, and we know that fluoxetine is one of the antidepressants that has the longest half-life, and so takes a little bit longer to give full efficacy, it may be a bit misleading. However, the data that show that combination is best is generally reliable per multiple other studies that have been done. So really using light therapy in addition to whatever else is being done would be helpful. And it was also noticed that it was pretty well tolerated in the study, which was for regular major depressive disorder, not just a seasonal variety, which is where typically light therapy is more often talked about. Another study on exercise, which looked at meta-analyses of about 39 randomized controlled trials. And these were done between 1979 and 2010. And when you read the study, it's like the authors were banging their head against their computers because it was so hard to find studies that are really reliable in terms of exercise. Some of them were using cardiovascular exercise, somebody was using weight training, somebody was doing something different. So they really had a hard time pulling together the data. But when they looked at it, there was about 1/3 men, 2/3 women, age range, kind of a general adult age group. They did notice that exercise almost across the board was associated with greater reduction in depression scores. And this is sort of like your, mom or dad would say, go run outside, go do something, you'll feel better. And we know that that doesn't really work for depression, but on the other hand, this meta-analysis does show that it adds to it. So using something like behavioral activation, having an area where you can encourage patients to go for a walk or go for a run or do something, even if it's guided exercise, may be a helpful thing to do. Another study for yoga and depression. This was a review and meta-analyses. And as you'll notice in a lot of the complementary and alternative, we end up going to meta-analyses or Cochrane reviews because it's just hard with something that doesn't make you money like yoga, that there's nobody really ready to fund those studies at a large scale. So you end up using a lot of these smaller studies instead. They noticed that yoga was one of the most commonly used mind-body interventions. They selected 12 randomized controlled trials. They had about 619 total patients, but given the quality of the yoga and the ability to assess it, they finally ended up using 9 of those for this analysis. And they noticed that when you look at yoga as compared to other controlled interventions, you were able to separate things into short-term and long-term effects. The main difficulty was that these are just, the quality is a bit questionable. However, the take-home point is that there is some moderate evidence for short-term improvements in severity of depression if you use yoga. And then when you analyze that data further, meditation-based yoga interventions were actually more effective than the super complex downward dog and then, get into plank and the more exercise-based interventions. And so this may be a little bit more aligned with the psychological data that do show mindfulness-based interventions and mindfulness-based psychotherapy effective for depression. However, yoga, if you are able to do it more from a mindfulness perspective and a meditative perspective, maybe that combination of exercise and improvement in depression. And then finally, acupuncture. This was one of the areas where doing sham or placebo control was very hard. However, in the Cochrane review that I looked at, they had about 64 RCTs that they looked at. It included manual acupuncture, electro-acupuncture, and something called laser acupuncture. And that was the first time I'd heard of laser acupuncture. But manual acupuncture is where you use the physical needles. Electro-acupuncture is they have sort of an electrode that can be used in the same way. And then laser acupuncture was using sort of a laser device with a laser beam that essentially did stimulation of the areas in a similar way, the medians. The result was that there was some low quality evidence, so low quality because the studies were done in various different ways, but it did seem to help reduce the severity of depression. And I think the way I think about acupuncture for depression is if a patient's used to doing it or likes it and believes that it would be helpful, then I'm happy to utilize that placebo effect as well as the data from this Cochrane review to support it for depression. It may not be a thing that I'm spending a lot of time and energy encouraging a patient to go do, but if it's easily available and they're willing and able to do it, it may be something that should be done. And a lot of acupuncturists are very skilled individuals when it comes to sort of mind-body interventions. So if nothing else, it'll also add to that meditative element of treatment. Finally, neurotherapeutics. I took out quite a few slides for TMS to leave that for Dr. Hunter, but that would really be one of the big ones to talk about. So repetitive transcranial magnetic stimulation. Then there's ECT or electro-convulsive therapy. That was actually the first neurostimulation modality that I started doing right out of residency and started an ECT service. So for anybody who has a lot of stigmatized thoughts about ECT, come talk to me. There's good ways of doing ECT and not great ways of doing ECT. And one that flew over the cuckoo's nest is wrong. That is not how we do ECT. We're nice people. We don't put anybody through that kind of torture. Then there's now some evidence for transcranial direct current stimulation. There's evidence for vagal nerve stimulation, deep brain stimulation, which is considered investigational just because it's hard to do RCTs. And there's only about 5 centers in the country that do DBS. One used to be here at the U of A in Tucson. And I recently heard that our neurosurgeon who used to do it is moving away or has moved away. So we may be down to 4. And then there's magnetic seizure therapy, which is also investigational. The ones that are bolded are FDA approved. So RTMS, ECT, VNS, DBS are actually FDA approved interventions. When it comes to ECT for treatment-resistant depression, this really has been the gold standard for treatment-resistant depression for a long time. And it used to be that, electroconvulsive therapy was used indiscriminately for some decades, because of which it has earned a bad reputation. However, it has been used in clinical psychiatry for over a century. And what we noticed for a long time was there was further down in treatment algorithms. So the American Psychiatric Association puts out treatment guidelines, and it was like, whoop, way at the bottom. And the most recent guidelines that are coming out of different places encourage individuals to use ECT sooner. And that's really what all of the data also shows, that you want to get it in your treatment algorithm a lot quicker, because the longer a person has been in that treatment resistant space, the harder it is to even get benefit from ECT. It's most often used for catatonia, psychotic depression, and then treatment-resistant depression. And then with catatonia, there can be a lot of different beliefs, but essentially catatonic depression, but also catatonia of any kind can be treated with ECT. And then we generally want to make sure with ECT, like I was saying earlier, that it's used fairly early. Deep brain stimulation, there can be pretty strict inclusion criteria. Most facilities that will do deep brain stimulation will be academic centers, which have a neurosurgery department as well as psychiatry, and they joined together to assess people for deep brain stimulation suitability and then perform the treatment. They usually have to have non-response to at least 4 gold standard treatments. So you really have to have followed the treatment algorithm with your patient for them to be able to be a candidate. They need to be medically stable to have surgery. And then they also need to really understand what they're signing up for, because you're essentially opening up their brain to stimulate it. There are some exclusionary criteria: psychotic disorders, any suicidality or suicide attempts, comorbidity, severe personality disorder, history of bipolar disorder. And so I think, again, with the complex patients that we see, it's very difficult to find somebody who meets that criteria. But there are individuals who have pure depression and just really severe depression, but they're motivated and they could be a candidate. There are some studies in DBS. Typical areas that are stimulated are the subgenual cingulate, the ventral capsule or striatum, and then the medial forebrain. And when you notice with DBS, it does have a really great response rate. However, it continues to be in that human trials category, so it is still considered experimental and takes a long, long time for somebody to get that treatment, but always good to consider if you're out of other options. So these are all the different areas we covered: psychotherapy, psychopharmacology, nutraceuticals, CAM therapies, and neurotherapeutics, which we'll talk about more with Dr. Hunter. And the goal of using all of these is to make the world a better place for all those who are suffering with depression. And if you're here, here to help your clients or to help your patients, which is what I call all the people I work with, or even for yourself, you want to make sure that you're trying to address it through all those modalities, so that you can have the sweet result of being able to get back to your life, being able to really be back to being with your family and being effective. And I'll end with a quote from Anne Frank. "I don't think of all the misery, but of all the beauty that still remains." And this is really the way that I can stay motivated when I work with individuals with complex mood disorders on a day-to-day basis to help them with their treatment. Because even though there's a lot of things that are keeping people stuck, there are also a lot of tools we have to help them move along. And then these are my references, which are available. If you need them, you can request them. This is my social media handles. I'm on LinkedIn, Instagram, and I'm trying Twitter. It's super hard. I only got to social media in October. And so if you have tips on that, please let me know. And you can email me at my Sierra Tucson email, which is my last name my first name dot my last name at sierratucson.com. And I would be happy to take any questions at the end after Dr. Hunter's presentation.
Thank you, Dr. Chatwell, for your great presentation. It was very informative. Now it's my great pleasure to introduce Dr. Ben Hunter. Dr. Hunter is our Medical Director of Professional Services at Skyland Trail. He manages psychiatric services, psychological testing, adult family therapy sessions, transcranial magnetic stimulation services, the Glenn Family Wellness Clinic, as well as the Wellness Clinic at the Adolescent Campus. Dr. Hunter joined Skyland Trail as Medical Director of Outpatient Services in 2016. He completed his medical training at Emory University, followed by psychiatric residency at the University of Pennsylvania, where he served as chief resident during his final year. Additionally, Dr. Hunter has completed fellowships in psychoanalysis through the Psychoanalytic Center of Philadelphia, and also organizational psychiatry with the Group for the Advancement of Psychiatry. During his training, he received numerous distinctions, including the University of Pennsylvania's Laughlin Foundation Award for Outstanding Professional Achievement, as well as the Kenneth D. Cohen Psychodynamic Psychotherapy Award. Please join me in welcoming Dr. Hunter.
Thank you very much, Julie, and thanks, Dr. Chatwell, for a fantastic overview of such a broad category of treatment here and diagnosis. I think either one of us probably could have spent 45 minutes speaking about any one of those categories in and of themselves. So thanks for that run through. That certainly helps lead into my discussion about one of our more exciting and if I can get my slides to advance here. There we go. One of our more exciting, efficacious, and disproportionately weighted treatments in terms of benefit versus risk in the field of psychiatry that really is only gaining momentum as the years go on, and that's transcranial magnetic stimulation. So without further ado, I'll just mention I have no true conflicts of interest or disclosures. We own systems produced by both MagStim Company and MagVenture. I will not reference those specifically other than just to mention, you know, the paradigms we may use, but no financial conflicts beyond that. You know, I'll speak a little bit about, you know, why we need neuromodulation. And again, Dr. Chotwal did a fantastic job of outlining the implications of treatment resistance and depression and the outcomes of patients who have treatment resistant depression. So we won't need to spend much time there. We'll talk briefly about history and the neuroscience behind TMS, which patients are most appropriate and eligible for TMS, what the experience is actually like for patients, and then next steps in the research and delivery of TMS as we move forward with the science. So first, a broad overview, and again, Dr. Chotwal covered this partially. Neuromodulation as a category, these are non-invasive and invasive techniques designed to specifically stimulate certain nerves or neural networks, as opposed to something like a medication, which, you know, again, is a systemic approach that ends up affecting the brain and neurotransmitters in a certain way. These are very directly targeted treatments targeted for certain nerves or systems of nerves. Examples, again, TMS, deep brain stimulation, VNS, and spinal cord stimulation, which is a non-psychiatric application, but just to mention, this is not limited to psychiatry. And the goal with all these treatments and also ECT is to modulate these neural pathways and allow them to function more like they function in a non-pathological state, meaning a non-depressed state when we're treating TRD. And again, TRD is so prevalent in the United States and in the setting of depression being a major health issue worldwide. Again, with 16 million Americans as of 2016, the most recent SAMHSA data we have, having at least one depressive episode, and with STAR-D showing that somewhere around 30% of those patients who went all the way through the algorithm, which is extremely arduous and side effect heavy at the end of the algorithm in particular, still not achieving remission. You know, again, we need something that has, again, higher efficacy, easier methods of access. And, you know, these patients are, as we know, and as Dr. Chotwal mentioned, patients who are typically seeing lower productivity in terms of their life and work. They have higher medical comorbidities, and they have more suicide attempts. So really the most critical outcome that we want to avoid in depression, besides just overall loss of functionality, is certainly suicide. And we know these patients are at risk in particular. So finding better treatments is a critical goal of the psychiatric field as a whole. And TMS has been one of those treatments in the last few years. Issues, again, with our current treatments between the meds and the therapy, and again, lack of efficacy with STAR-D data that Dr. Chotwal mentioned. You know, by the time you're looking at level 3 and 4, sustained remission, meaning a year plus, which is what I think anyone wants when they get treated with depression. They don't just want to get better for a few months, they want to stay better. You're talking 5%, 3% when you're reaching levels 3 and 4. Not to mention, by the time you're down at that level, which again, this is the group we're usually considering for TMS most directly, at least at this point in the FDA approval and insurance coverage game. They're also experiencing a significant rate of side effects with their medications. Again, discontinuation rates as high as a quarter to a third of patients when they're reaching levels 3 and 4 in STAR-D. So again, those are your tricyclic antidepressants, your add-on lithium and thyroid hormone, and then MAOIs, monoamine oxidase inhibitors, which are traditionally very difficult to use, although highly efficacious, and again, should be considered in far more patients than they are currently used. But with all this in mind, we want treatments that are more targeted and less systemic, meaning, again, you know, putting a medication into the system of a pregnant woman, for example, or an older adult on numerous other medications for general health concerns, or a child, has the risk of side effects as it's processed by the whole body, essentially, and available to the whole body. Again, for these specialty populations in particular, we want a treatment that doesn't require so much systemic involvement if we can. Again, more durability, you know, a greater degree of effectiveness, fewer side effects, and, you know, particularly with at-risk populations, less concern about their impact on that person's overall health. And here's where we come to TMS. So just a quick picture of the TMS room at Skyland Trail. We actually just got our brand new system. This is our old MagStim system, which was a repetitive TMS system. We'll talk a little bit about the difference between repetitive TMS or RTMS and theta burst TMS, which is a new technology that's offering a really nice evolution of the TMS experience for patients and may offer greater effectiveness down the road too, it seems. But what you can see here is basically a very comfortable dentist style chair with a headrest, and then that sort of Mickey Mouse eared magnet over the top right on the screen of that headrest is the TMS magnet itself. So, with a technician typically delivering the treatment, they will position that magnet directly next to the patient's head, lightly touching the head, and then again, using a targeting system that we will discuss here in a minute, will allow the magnet to basically provide the treatment. And we'll talk in a lot more detail about what that entails. I'll move quickly through the history, just given time. But again, we've known about the relationship between magnetic field and electrical current since 1831. A guy named Faraday, which some of you may have nightmares about from high school and college physics classes. By the time the 1900s came around, and particularly up to in 1985, you had Tony Barker really targeting TMS as a treatment for mental health disorders, particularly depression, at that point. By the time 2008 came around, now you have FDA approval for TMS as a treatment for major depressive disorder. You initially had one machine that was cleared. It became 5 machines or 5 different manufacturers clearing devices by 2017, up to 7 at this point. And then in 2019, we had another breakthrough with theta burst stimulation receiving FDA approval for treatment in depression. Just other points worth mentioning, 2019 was also when deep TMS, a different type of TMS, was approved for the treatment of obsessive compulsive disorder. And then other indications like nicotine cessation coming along year by year, which is really exciting, given how much of an impact some of those other disorders have on people's life and health outcomes. So again, with the FDA approval coming in 2008, we have changed TMS significantly since then, although the overall approach and modality is largely unchanged. It's mostly the specifics and the protocols and the technology of the machines that's changed in the last 12 or 13 years. The bottom line is that this device uses electricity to generate a magnetic field. The magnetic field, which is on the order of an MRI machine, induces then an electrical current in the brain. So we're able to locally target this electrical current to areas we know are implicated in depression. So in the broadest sense, we're looking at the limbic system, which modulates mood and anxiety, among many other cognitive and emotional functions. And we use the limbic system, we use the dorsolateral prefrontal cortex as the area of the limbic system that allows us a gateway into the modulation of that system and a way to regulate mood and anxiety in particular. What we know is that in the left dorsolateral prefrontal cortex in depressed patients, it tends to be hypoactive, meaning if you look at a functional MRI image, you will see decreased metabolic signals and decreased blood flow in that area. On the right side, on the other hand, you actually have hyperactivity typically in patients who are depressed. So again, you'll see more metabolism, more blood flow than you would expect in a non-depressed person. And what we do with TMS is essentially depolarize those local neurons at the prefrontal cortex using that electrical current. And that regulates those pathways that modulate mood and also anxiety as a part of the treatment. So again, that limbic system, everything involved, including emotion, behavior, motivation, memory to a certain degree, and even in sense of smell, it's all accessible via the limbic system, which we can target using this magnetic field and the induced electrical current. You can see that little blue area on the brain figure below. That is the rough correspondence of the dorsolateral prefrontal cortex. Again, the cortex being that outer layer of the brain. So mechanistically, we're activating that limbic system, and by modulating those neurons, we can stimulate release of neurotransmitters. And again, we know that availability of neurotransmitters like serotonin, norepinephrine, dopamine is critical in brain functioning and healthy brain functioning in particular. It's not as simple as being a bag full of neurotransmitters. I think there used to be the approach when we first learned about medications that would work, decades ago, that if we just increase the overall level of serotonin or norepinephrine in the system, we'd probably cure depression. It's a lot more complex than that. It's a lot more network-based. We'll talk a little more about that, but certainly making those neurotransmitters more available does seem to help in the general sense. By using TMS, blood flow and glucose metabolism rise in the areas they should rise in, like the left dorsolateral prefrontal cortex. And what we see, again, what I was just referencing, is that neuroimaging studies will show you improved functional connectivity between areas of the brain. So this is really where we think the long-term effect of TMS may come from. Essentially, again, changing the way the brain communicates within itself, and then also improving both inhibitory, meaning typically it's usually anxiety and impulse control functions with the GABA system. By improving the tone of the GABA system, we promote anxiety regulation, impulse control, kind of rational decision making, all the things that come and along with good cognitive behavioral therapy treatment, for example, but are also targeted by TMS and other treatments in a more general sense. And also glutamatergic or excitatory tone. So again, you can see how modulating both the gas and the brakes a little bit could have a dual effect on helping the brain function in a patient who's depressed and anxious, typically. Very rare to see a patient who's reached treatment-resistant depression phase and not having at least some element of anxiety being a part of their presentation. So, who's a candidate? Which patients do we actually consider for TMS? And this is, again, I think I'll throw the caveat in that given the safety profile, which we'll discuss, I think we should be considering TMS earlier in the treatment algorithm for many more patients, meaning before they have failed all the trials I'm about to tell you are necessary to get TMS approved by insurance. And we're working on that as an organization. I will actually be at the Clinical TMS Society annual conference this Thursday and Friday down in Palm Beach. And one of the major targets of this conference is presenting new data, and particularly data that's going to help improve access and the number of indications that we can use TMS for, meaning the number of different disorders we can treat with TMS with FDA approval, and therefore what typically follows insurance coverage. So the FDA says you have to fail at least one adequate trial of medication or therapy during the current major depressive episode to qualify for TMS. Insurance companies bump that up to 4 trials typically. This is constantly evolving. I still see it centering around the number of 4. So 4 medications, at least 2 classes, and they have to be adequate trials, meaning they were usually increased to a dose that would be expected to work, and or side effects came into play that made it intolerable at a certain dose. Along with, it's typically 6 months of psychotherapy, and it needs to be an evidence-based modality. So again, all the therapies Dr. Chatwal mentioned, cognitive behavioral therapy, interpersonal therapy, those are the most common we see, psychodynamic therapy, those all count, and it usually needs to be 6 months, and they typically want weekly, sometimes every other week treatment to count. I will also say, just as kind of a Ben Hunter statement, not necessarily a Skyland Trail statement, although I think most people in our treatment program agree, biological interventions really are meant and function best when they lay the groundwork for good psychotherapy. So this creates a stable platform from which people can do the real work that helps them function and change their lives and their narrative over time, which is the psychotherapy. So one more psychiatrist saying, and certainly a psychiatrist with a lot of training in psychotherapy, but I think that psychotherapy is the definitive treatment for most mental health issues, certainly with some exceptions. You are never going to find any of us treating bipolar disorder or schizophrenia with psychotherapy alone. That's unethical. But for depression and anxiety in particular, I think the definitive treatment, the treatment that really helps people stay well over time, is developing a new understanding of their past, present, and future through psychotherapy. So, and just one more psychiatrist who has nothing to gain from saying that other than just getting patients better. All these things we're talking about, medications, adjunctive treatments, TMS, all meant to really lay a groundwork for people to do really good psychotherapy work. And we essentially require that. I mean, we do require that for our patients in our residential program. I strongly encourage it for our outpatients as well. And basically, if someone's not in psychotherapy while they're asking for TMS from our outpatient program, I'm going to be a little bit skeptical, and I'm usually going to have some kind of stipulation that they're going to need to at least strongly consider starting psychotherapy as part of their treatment or as part of their recovery beyond the TMS treatment. Partially because I know maximal satisfaction from TMS by getting better and staying better is going to be absolutely supported by good psychotherapy. So with that aside, we can also, again, use this off-label. I think it is used quite a bit off-label at this point, meaning in ways that are not approved by the FDA directly, which does not mean they're not safe. It just means they haven't been studied sufficiently to garner that final FDA approval. But patients who are well stabilized with bipolar disorder, meaning they have mood stabilizer medications that are dosed adequately to prevent a manic episode during TMS, we will definitely consider. patients who have more primary anxiety than depression, we've got enough good data to suggest this works in anxiety that I'm happy to consider someone. Again, the issue is often that without FDA approval, the insurance companies are skeptical about covering it, so it turns into an out-of-pocket cost. Contraindications, the absolute contraindication, and the one and only for TMS really, is a metal implant in the brain or within the immediate area of the magnet. So 30 centimeters is a very conservative length from that magnet to use in terms of evaluating whether a magnetic implant may be, or a pacemaker or any other kind of electrical device may be at risk. The issue here is actually, it's not the suction effect of the magnet like I think many people imagine, it's the heating effect. So iron containing metals will heat up under magnetic field, which is why you can't do TMS with someone with a skull plate, for example, after a skull fracture. Everything else essentially is related to risk of seizure, which is a very, very rare and frankly, somewhat clinically irrelevant risk factor in TMS with the average person, but it is something we want to be sure to avoid if we can. So history of seizures or epilepsy, history of head trauma, meningitis or encephalitis or other brain infections, and then substance use, especially substance withdrawal from GABAergic, benzodiazepine medications or alcohol, are things that can increase your risk of having a seizure, and therefore can be used as relative contraindications to TMS, meaning it's a risk you need to certainly talk about with patients and may actually prevent the insurance company from covering it too. Psychosis and mania, there's the risk of driving mania in a patient with bipolar disorder using TMS. Just like with antidepressant medications, if you don't have a mood stabilizer on board and you give someone adequate doses of antidepressants, you are putting them at risk of having a manic episode. Again, that's something we consider case by case. Currently, I don't know any insurance companies who cover it for bipolar depression. Psychosis is not about a risk of driving psychosis as much as it is about the fact that it seems to not be as effective in patients who have major depressive disorder with psychosis. I could go on about this for quite a while longer and why I think that is a misrepresentation of statistics. I think it's more about the overall severity of those patients than it is about the actual element of psychosis being a different presentation biologically, but that's an entire another talk for another day. So here's what we do, and again, I'll move kind of quickly through this again, given the time. We measure the motor threshold, which is the amount of power, using our magnet, the amount of power needed to get a muscle twitch in the thumb or forefinger of the contralateral side of the body. So we basically put this handheld magnet up to the head, and we drive a single electrical pulse or a single magnetic pulse and electrical current into an area on the motor strip that corresponds to the fingers, and we watch to see which power is the minimum amount we need to get those fingers to move. And what we know from lots of good research is that if we move about 5.5 centimeters forward from that spot, we have located the dorsolateral prefrontal cortex, which again, we're targeting in treatment. That is something that has become more accurately specified using other measurement paradigms, and I'll talk a little bit about that. But the initial treatment was done with using just 5.5 centimeters forward from that motor spot. The old style, this is again, I can officially say the old style at this point, given the fact that almost no one does the old standard research protocol anymore, but used to be a 4-second burst of magnetic pulses followed by 26-second rest at high frequency on the left side only. So it was 10 hertz to the left dorsolateral prefrontal cortex. 3,000 total pulses seems to be somewhat of a magic number here. And patients would have 5 sessions a week over the course of 6 weeks, followed by a 6-session taper that was typically 3 sessions, 2 sessions, 1 session over the following 3 weeks. So 36 total sessions over the course of 8 or 9 weeks. In around 2016, 2017, you had more centers starting to use this shortened protocol that Neuronetics branded the DASH protocol. This is the NeuroStar company for people that are familiar with TMS. Essentially, they showed that it was very safe and equally effective to reduce the time between pulse bursts from 26 seconds down to, on the low end, at least 11 seconds or so. So that obviously significantly reduces the amount of time the patient's in the chair, makes it more accessible to more patients. That was a great move forward. That's what we were doing for quite a while at Skyland Trail, from essentially 2017 to 2020. And that was also FDA approved, that new timing paradigm. And then, again, another way of increasing effectiveness just comes through more customization. And as we get more and more data, TMS is one of those fields where the providers who are doing, good TMS, really the high-end TMS, are looking frequently at the data to see what new information's out about delivery, about power settings, about, again, which different spots on the brain can be targeted to treat different symptom clusters, discussing that with their patients and choosing a treatment that seems to fit best, as the FDA and other governing bodies just cannot possibly move as quickly as the research is moving at this point. So again, that measurement I mentioned earlier, the 5.5 centimeters forward from the motor spot, has been improved significantly by using a method called beam, which is much more attuned to the person's head size, which seems somewhat important if you're going to be trying to figure out where a spot on the brain is underneath the skull itself. So we've used that since the beginning. Actually, that's been around since, I want to say, 2015 or 2016, really in widespread use. Adding on right-sided treatment, which was another breakthrough in the last few years, where essentially it was proven that right-sided low-frequency treatment, again, inhibitory treatment on the right side of that hyperactive dorsolateral prefrontal cortex, was independently shown to equate roughly to the results we got from left-sided treatment. So again, both left side and right side treatments independently evidence-based to treat depression. And again, that's a different protocol, but it's one that is easily added on following the left-sided treatment. So what most good centers are doing is essentially doing a left-sided treatment followed by a right-sided treatment, which really seems to add to the effect of either one individually. And also, by bringing the hemispheres into concordance, seems to do a better job of treating anxiety overall. When there was the initial treatment with left-sided only TMS, there was some concern that it may sort of have a crossover effect where that excitatory stimulation may overstimulate a right side that was already running too hot. So I think by adding in that right-sided modulation, you've really got a nice effect, especially in patients who come in with high levels of anxiety along with their depression, which is quite a few patients we treat. So again, before theta burst came along, and we'll talk about that in just a minute, and this is more common, most centers you send a patient to at this point are going to take about 37 minutes if they're doing bilateral treatment. It's usually somewhere around the 20-minute range for the left side, somewhere around 12 or 15 minutes on the right, and then the time it takes to set the machine up. The head's immobilized, but the patient can usually read or watch television or meditate or do anything else they want to do as long as they're not moving their head. There is a fairly loud clicking sound generated by the magnet, such that it necessitates the use of earplugs during the treatment. And then side effect wise, very, very common, especially with the previous repetitive TMS stimulation treatment paradigm, to have some discomfort at the site. So you've got this magnetic pulse, which feels kind of like a tapping sensation. I wouldn't call it pleasant. I also wouldn't call it outright painful for most people, but that usually improves over the first few weeks as the scalp acclimates and as those nerves start to filter that out as background noise. Not uncommon for patients to have a headache after the first few sessions or so. Again, usually right on the edge of requiring something like Tylenol or ibuprofen to treat. It's usually not severe, and usually, again, resolves within a week or so of starting treatment. Occasional neck pain, I think that's just more the positioning of the magnet needing to keep your head still for that period of time. But all these things respond well to your basic over-the-counter analgesics, which is what we typically recommend patients use. Patients can immediately return to work or other activities following their session. So this is not going to impact memory in the same way that ECT does. Again, I'll throw in another plug for ECT being a fantastic and underutilized treatment for depression. There are real memory issues that come along with ECT for many patients. So the nice thing about TMS is if they're not quite at the point where ECT is completely necessary, you can give TMS a trial. And there's usually a little less impact on the day-to-day work and or just life scenario where, again, memory's still fully intact, maybe even a little bit improved. I have no data to back that, but good theory. Time to improvement varies heavily. You see a very widely distributed curve in terms of when people start to notice the response. It seems to be, again, incremental, and I would say most people typically notice something significant changing around week 2, 3, 4. Should absolutely continue medication and psychotherapy. This is an add-on treatment, not a solo treatment. It can be used as a solo treatment in patients with contraindications, who can't tolerate medications, who are absolutely against the idea of using an antidepressant during pregnancy, for example, or something like that. But the recommendation for best effect is to combine it with good medication therapy and good psychotherapy. And it is covered by almost every major health insurance plan. So, we're in network with virtually all the big ones, and they do a great job of covering it, which is great. That seizure risk we mentioned earlier. So in the early trials, which used older technology in terms of the magnet and also stimulated at a site that was closer to the motor strip and therefore more likely to cause seizures, saw seizures in about 1 out of 1,000 patients. So I'll tell you right now, the risk of seizure is higher in most of the medications patients are prescribed, and they never hear about seizures as a risk. It's scarier because you got a magnet delivering energy directly to the skull and to the brain. I think that factor is certainly worth mentioning to patients. I've never had a patient become overly concerned about a 1 in 1,000 risk of having a seizure. We adjust that number slightly if, again, they've had some of those other relative contraindications like head injuries or serious infections. But overall, it's a somewhat clinically negligible risk that we certainly discuss with patients nonetheless. Again, I already discussed that increase in anxiety that you saw in some cases. I think that was honestly more related to the unilateral treatment, and I have not seen that. And the data from bilateral treatment does not seem to bear that out. And again, no associated cognitive issues, which is great. Effectiveness-wise, again, we've had over 30 large sham-controlled trials since the beginnings of TMS research in the 1990s, over 2,000 patients included, and this is just in the sham-controlled trials, which is a large number for sham-controlled trials. The old statistics about, half of patients responding, meaning 50% improvement or more, and a third of patients remitting, meaning getting to that designated spot on the Montgomery-Åsberg Depression Scale or the PHQ-9 or the Hamilton Depression or the Beck Depression Inventory. Those numbers were used to be closer to a third of patients. And I think that's largely believed to be outdated at this point. With neuronetics driving one of the bigger trials in the last few years that's actually still going on in terms of follow-up work, you had thousands of patients, 3,800 patients roughly who were measured using their own self-report scales, and about 1,200 patients who were subject to the treatment and then physician report scales. You're looking at somewhere around, with the physician report scales, 3/4 of patients responding and over half of patients remitting, which is obviously a significantly different set of numbers than we just looked at with a half and a third. Physician report scales tend to be a little more accurate. They do tend to better reflect, I think, patient recovery if you look at the research on different scales and how they're used in depression. So while patients may be very reticent for a number of reasons to move towards recovery and embrace the change that's happened, I think for a lot of very good reasons, physicians are a little bit more objective typically. And again, you're looking at really high numbers for improvement with physician report scales. And a lot of this is about bilateral treatment. It's about newer machines that deliver the pulse more effectively. All of these things are improving year by year. What we've seen, and this was now collected a few months ago, we're up to almost 100 in terms of our patient count at this point, but we had about an 81% response rate and a 55% remission rate. So not far off of those physician report scales. We used the Montgomery-Åsberg Depression Rating Scale. Not only were they improving, again, the average improvement, including all the patients who didn't improve at all, or I guess theoretically gotten worse, you're looking at a change of an average score of 30 down to an average score of 9, which is someone who's just above the point at 9 of being in remission and is functionally in a significantly different place in their life than when they had a score of 30. Someone in the 30 range is usually moderately to severely depressed. They are not functioning well. Someone at 9 will tell you they are largely not seeing depression as impacting their daily life. And also, I mean, what was even more remarkable potentially was the change in the Hamilton Anxiety Scale scores when we were collecting this data initially. Average of about 23 down to about a 7, which again, significantly less anxious. Not only do we not have people get more anxious, which some people are concerned about, they got substantially less anxious using that bilateral protocol. Again, compare this to STAR-D, where by the time they're reaching the TMS point of being at step 3 or 4, you're talking a 7 to 10% range of response. So again, just bringing that data back up in terms of durability, if you look at each level of STAR-D and you look at how they're doing in terms of continuing to respond over time, you're looking at a substantial number in that right column of patients who, during the continuation phase, meaning beyond the initial treatment, will relapse. So again, at stage 4 of that treatment, up to 70% of people relapsing, unfortunately. Again, high numbers in even steps 1, 2, and 3 as well. So we need something that's going to work better and for longer. Being mindful of time here, I'll make sure we have some time for you guys to have questions when we finish up here. Again, the bottom line is that TMS is a very durable treatment compared to most other treatments. A lot of different studies conducted between the early 2000s and current. One systematic analysis that did a particularly good job showed sustained responder rates of at least 50% at a year. So again, you're looking at a treatment that for most people will last months to years. Maintenance protocols. So none of them are FDA approved yet, which is a major problem. That's one of the biggest things we're trying to address as a field right now. Again, getting maintenance treatments approved by the FDA so that insurance companies will cover them and patients can continue to get maintenance treatment after their initial course. Having achieved a good response, we want them to be able to sustain it. And for some people, it does seem that either doing, again, little boosters here and there, meaning a few sessions every month or two, or what's more commonly used, I think, between the bigger centers now, planned maintenance of perhaps a session every 2 weeks, which is what we have a lot of patients on at Skyland Trail and seem to respond really well to. We kind of tailor it according to patient needs and we see how they do and we adjust accordingly, certainly with some variability, but one session every 2 weeks seems to do a really good job for people and also be serve as a minimal impact on their day-to-day life in terms of scheduling and things. That's just very convenient for them to come over once every 2 weeks. There's a lot of great data suggesting that these things will, these different modalities of maintenance will extend the time that TMS works and the time to relapse. Insurance industry is, again, continuing to refuse to pay. They say that it's a lack of empirical evidence. I'm not sure what more they need, but we have to be close is all I can say. At a certain point, it's going to cost more for them to treat people with subsequent courses of TMS than it will be to just allow maintenance, which we all know works at this point. So we're hopeful and we have our fingers crossed that's coming here soon. So just a couple quick touch points. I mean, that's kind of the basics around TMS. We'll talk about new frontiers. I particularly want to mention theta burst. This is an image of the connectome. So this is a concept that some of you might have seen in the literature around depression and mental health as a whole. This picture here, not just graphic art, this actually represents a much more current view of how we think about the brain. So what you're seeing there are all those little lines that connect different areas of the brain, show the relative connectedness of certain areas to each other. So the degree to which they operate in sync when one area is stimulated, for example. And actually TMS can be used as a research device in this area. This is how we think about mental health in an increasing degree as we move forward. Again, it's how different areas communicate, how different networks work. So in terms of general overview to new frontiers in TMS, we're talking about new treatment protocols, finding new treatment sites and optimizing the power and frequency and number of pulses we use at each site. And then again, using TMS for new indications, new different reasons to use TMS, like anxiety disorders, for example. So first, theta burst, which we're now doing at Skyland Trail with outstanding results with patients. Patients have loved this transition. We got our theta burst machine in the last few months, and we have done theta burst now with, I would say, 12 or 15 patients. A couple of whom, by their own voluntary choice and with a full discussion of the data or lack of data around switching, wanted to transition from traditional RTMS to theta burst stimulation. And first thing they said was, like, I can't believe how much easier this is. I can't believe how easy this is to tolerate. And really the core of it is that we've now got a treatment that's reduced in time. The time obligation daily has gone from 37 minutes down to about 4 minutes. So patients love this for a variety of reasons, most of which is they can do it and get right back to work or get back to their family or whatever they're doing. So TMS, or excuse me, theta burst stimulation, TBS, functions by mimicking the endogenous rhythms of the neurons themselves using patterns of bursts rather than just regularly timed pulses like we had with our TMS. So again, essentially better mimicking the way the brain and neurons function naturally in order to modulate them more effectively. Again, this is thought to not only just improve the immediate functioning of the brain, and you can see, again, the metabolic changes and the functioning changes right away using neuroimaging, but it also seems like this may induce long-term potentiation of these networks in a way that means that the treatment will sustain itself for longer between sessions and, again, into the maintenance phase, which is what we really want and need. This is all being studied now, and there's not hard data around any improved effectiveness long-term yet with theta burst versus regular RTMS. So I still encourage anyone who has access to only RTMS locally to go for that. I mean, it still has great results. It's just that theta burst, as we look at it, I wouldn't be surprised at all if it seems like theta burst has a more durable response than RTMS. Again, not yet evidence-based, but that's the sense, and that's what the mechanism certainly would bear out. Again, it's more efficient time-wise. It takes 4 minutes, and it's more tolerable. It just, anything for that period of time seems to be more tolerable for patients, even if it's slightly more intense. They like the fact that it only lasts again, 3 minutes on the left, essentially, and 1 minute on the right. Just a couple quick references to the studies that gained FDA approval for theta burst. 3D was the big one in Lancet in 2018. Again, showed that it was equivalent to our TMS in terms of effectiveness. Really exciting, new frontier here. The SAINT protocol out of Stanford. This is a research protocol that was done using somewhat unrealistic clinical circumstances, which really could only be simulated at this point in a big study like this. But essentially, they gave 21 patients 10 sessions of theta burst a day for 5 days and achieved a 91% remission rate in those patients, which speaks to the fact that we're probably looking at the overall dose of TMS as opposed to the timing and duration of the course. They had results in 3 days. So you can imagine how this would seem to a patient who is either on the inpatient unit and only has a few days potentially to get a treatment before they have to go back out into the world and kind of treatment becomes less practical, or patients who are just severely depressed and don't want to wait 2, 3, 4 weeks for treatment. This is where the research is heading. I think you're in the next few years looking at many more FDA approved protocols, which include multiple sessions per day. Again, more evidence behind that. Jonathan Downer and his group up in Toronto, 5 days a week at 8 sessions a day. Again, they're getting response and remission rates that at a week are incredible. I mean, again, much higher rates as time goes on, but to be able to provide, and this is a more realistic outpatient setting that didn't include fMRI guidance like the SAINT protocol. Somewhat similar results. I mean, they're not at 91% remission, but I think, getting that type of response at 4 weeks and especially that quick response at 1 week would mean a game-changing paradigm for patients. And again, no significant safety issues, and there's more trials coming. And just what I referenced a minute ago with the connectome discussion in that first graphic, here's another representation of how we think about the connectome. We believe that neurologic and psychiatric symptoms are much more closely related to the way different networks interface with each other than a particular lesion at one site. For example, it's not just the dorsolateral prefrontal cortex being impaired or overfunctioning or underfunctioning that drives depression. It's the way that region then relates to the rest of the prefrontal cortex, to the amygdala, to the hippocampus, the degree to which they're connected and again, interact. That seems to be much more important. Again, the proof in point of that is that lesions in different areas of the brain that cause the same symptom are most easily linked by way of a network, a common network rather than a common site. So that just goes to show that, again, in TMS, we use the dorsolateral prefrontal cortex as access to the limbic system. That's the most easily accessible in terms of proximity to the skull and therefore, availability for treatment. But there's probably a number of other ways we could treat it using, for example, an electrode implanted in deep brain stimulation. There's some really interesting and I think highly specific and in that way, very encouraging research around different brain networks. Just some examples here on the screen. The salience network, which is involved in cognitive control and deficits therein. The reward network, so you're talking about patients who are suffering in depression from anhedonia and reward issues. And then the non-reward network, kind of the antithesis, which is people who are high neuroticism, high anxiety presentations, being overfunctioning in terms of their non-reward network, almost a punishment style network. Those different subtypes seem to probably respond to different types of treatment. And we know that psychotherapy wise, and it seems like that's probably the case with TMS and other targeted neuromodulation therapies as well. Again, just more on the connectome. And again, I see the time here. Again, there's great research coming out. This is a Harvard group with Mike Fox and Shan Siddiqui, by looking at different symptom clusters. So for example, what Dr. Chatwal mentioned, melancholic versus anxiosomatic depression seem to respond differentially to different treatment sites. We're looking at, again, that fMRI, functional magnetic resonance imaging, neuronavigation to really fine tune the location of our TMS treatment. That's what they did in the same protocol. It seems to have helped the results to some degree. Very expensive right now, so we're trying to find ways to make that more affordable and more commonly accessible. TMS EEG, which is using simultaneous TMS with an EEG, electroencephalogram. I'll show a picture of that in a minute. Also seems to really help both measure outcomes and improve outcomes. And then really advanced concepts like timing TMS treatment along with endogenous heart rhythms, which has very good evidence to suggest it may again, it seems like by way of working in tune with the sympathetic and parasympathetic nervous systems, help improve the effectiveness of TMS. That's also research being done right now with some great results. I'm gonna skip over the deep TMS for OCD slides here, just out of interest of time, but just suffice to say it's a different machine. There are also very good TMS treatments with standard TMS and theta burst machines that do not require a deep TMS coil. They are not yet FDA approved, but we have done off-label treatments for OCD here with excellent results for patients who have or have not actually had deep TMS before. That's a picture of your deep TMS coil. Kind of a carpet bombing approach to TMS. And again, just to mention that this is a very safe and well-tolerated treatment for kids, and it's also very effective. There's still the concern, and the reason why the FDA approval isn't there yet is that we still don't totally understand, to the degree that I guess we need to, the development of the cortex and the way that something like TMS, or frankly, many of the medication therapies, which are not FDA approved for kids and adolescents, which again, doesn't stop us from using them typically, but we just need a little more data on safety, it seems. But right now, very, very promising results. And we've also treated adolescents here, again, with full understanding that it's an off-label treatment with outstanding results. Actually, I would say in our very small subset, they're responding at an even higher rate than adults. There's your TMS EEG setup. So again, using this as a way to both research different treatment sites and also evaluate in real time the brain's response to TMS. You can see there's a cap that has EEG leads on there, which is measuring cortex activity, and then simultaneously a TMS coil being positioned there, which looks like it's positioned horribly, but in any case, I'm not going to ruin their marketing plan. That is a company that manufactures those devices so that you can do simultaneous TMS EEG. We have no relationship to them either, but free plug for them, I guess. Research around insomnia, PTSD has quite a bit of data at this point. The only issue there is getting it to separate out from placebo. It's got great results. It's just placebo also seems to have really good results, and especially veterans with PTSD. I don't see that as a problem, but again, it certainly is something we want to understand what amount of the response is biological and what might be placebo. Various forms of depression, including post-stroke and bipolar depression. There's research on Alzheimer's disease. There's certainly a lot of research going on in generalized anxiety, use in substance use and addiction. The list goes on. This is a really promising therapy that's extremely safe and well tolerated. Again, we have so many different sites we can target in the brain with so much potential to treat other conditions as well. I was just reading about, in the American Journal of Psychiatry, there was a study that looked very promising about using a sort of frontal area on the orbitofrontal cortex for OCD treatment, again, which could be a breakthrough. New studies out all the time. Theta bursts has improved the effect of the efficiency and the tolerability and may eventually prove more effective. Again, that's not proven yet. We have suspicion. Relatively low rates of relapse, better durability, again, improved targeting for different types of depression. And then again, more and more reasons to use TMS coming by the month. So with all that, very exciting treatment modality to offer. And one of that, that tiramisu approach that Dr. Chatwal mentioned, certainly in concert with great medication, evidence-based medication therapy, evidence-based psychotherapy, provides a really robust treatment for a patient with previous non-response to other modalities. And so that's really exciting, especially for patients who have reached that point of feeling somewhat hopeless and are really looking for anything to kind of move the needle in the right direction. So thank you very much. I think we've got a little bit of time left for questions now. So I'll go ahead and just scan through my sources as well.
Thank you, Dr. Hunter. Wow, you and Dr. Chatwal really has given us a lot of information in a time-pressured situation. So I am we do have about, 6 or 7 minutes for questions. And then don't forget, y'all, we're going to do a drawing for a couple of prizes. So I'm going to go to questions that are going to be a little bit more straightforward. 2 of them on TMS, Dr. Hunter, that are sort of related. And what if someone has undiagnosed schizophrenia or bipolar and they undergo this treatment? Can there be negative interaction or consequence? And related to that, I think, is the question that person has: if there are no indications of bipolarity, is there any reason not to try TMS?
Yeah, so to answer the first question, for someone with bipolar disorder that's undiagnosed, you may, given a very potent antidepressant therapy in TMS, you may have a risk of generating a manic episode. So that's the biggest risk. The nice thing is with TMS, you're seeing a patient every day for the most part. So the ability to catch that, shift into mania quickly, and frankly, learn something very critical for that patient's treatment going forward, meaning that they have bipolar disorder and not just unipolar depression, which completely changes the medication therapies that we would choose. I mean, we don't ever want to induce mania in someone, and I don't want to wish a bipolar diagnosis on anyone, but if that were to happen, TMS might be the ideal place for it to happen because we'd be able to see it so quickly and adjust therapy to treat that. No deleterious effects that I can speak to in undiagnosed schizophrenia. I think the main concern with schizophrenia is largely that if someone has, for example, depression related to schizophrenia, it wouldn't be as effective as it would be for true, what we think of as biological depression, major depressive disorder. There's a lot of ongoing research actually into using TMS for the negative symptoms of schizophrenia, which, as many of you know, is a classically almost impossible to treat cluster of symptoms that really hampers people with schizophrenia over time. So that's really exciting research, actually. There's almost nothing that impacts negative symptoms of schizophrenia. So this would be a really exciting addition to that treatment paradigm. And then in terms of, why, other reasons why people wouldn't use TMS right off the bat, I mean, I think, it's time and money largely, and accessibility. I think if you're not treatment resistant according to your given insurance company, TMS will cost somewhere between $8,000 and $12,000, which is a significant financial, commitment for patients. You do need to come to the office every day for an extended period of time. So for some people, it's a little bit tough to negotiate. Again, much easier with Theta Burst. But those are really the two main reasons. The one other thing I'll mention briefly is that for patients in a subset of populations in TRD, those patients have a overrepresentation of other issues, as Dr. Chatwal mentioned, things like personality disorders, substance use disorders, patients who have, for example, just very difficult situations at home, sort of like trauma-inducing personal relationships or work situations that are abusive. TMS is not going to help those things. It's not going to change those things fundamentally, right? It may help a patient function better and therefore it change their life in a way that makes them, it makes it easier to support and makes them feel more healthy. But I am reticent to introduce too much of the miracle cure effect to people who otherwise have really rough situations going on personally, or who have a severe personality disorder which needs to be treated by mainly psychotherapy. I don't want them to believe that TMS is going to be the one thing that sort of fixes them, thereby reducing their buy-in for other modalities. So that's my other just concern that I'll mention.
Great, thank you. I think I'm scrolling through. This is more on, this is about ketamine. Do you know if the remission in symptoms from ketamine treatments last beyond cessation of ketamine, and if so, for how long?
That is an excellent question. Thanks so much, Dawn, for moderating. So ketamine it really depends on how the ketamine treatment is done. There are people who use ketamine off-label. There's a lot of anesthesiologists who started practices doing ketamine for depression because they charge kind of a cash-only type model. But it really depends on the quality of the ketamine treatment. With the intranasal ketamine, as well as with well-done IV ketamine, or even there are some IM studies, we do notice that the effects can last for a longer time. Usually initially it was thought maybe it would be a few weeks, but we do notice that similar to something like TMS or ECT, you can do an acute phase of treatment and then you can start doing maintenance treatment. So it can be effective. The big thing you want to make sure if you're sending your patient for ketamine treatment or your self-seeking treatment for yourself is that the person is truly paired with a psychiatrist who has a knowledge in how to use ketamine for depression, and that they're really looking at and assessing depression on a regular basis so as to know what your efficacy is. You don't want to just keep on going, because there are some boutiques that do ketamine which don't really follow those traditional well-studied models of using ketamine in depression.
Thank you. And I think that leads a little bit into the next question about ketamine. And that is about, that is an addictive drug, or a drug that is misused by people who misuse other drugs. So what's the interaction between, talk about that a little bit, please.
So ketamine is addictive, or can be an addictive medication, not so much so just from the way its own pharmacology is, but really more so because of the effects it can cause for a person, sort of like the psychological pleasure effect and stimulation of the pleasure pathway. So it can be addictive, and sometimes for some individuals, even just the idea of something being a magic bullet that's going to help solve their problem can make that thing addictive. So that's not a pharmacological effect, but really, again, that psychological addiction to it. With ketamine especially, I'm very careful when I'm recommending ketamine for somebody that I'm looking through their substance use history and really assessing, one, if there's any family history of addiction, substance use disorders, and if the person has that type of addictive bent themselves where they've had difficulty with that. And typically a lot of psychoeducation to let them know that we'll be monitoring depressive symptoms and doing some outcomes-based initiatives. And if they're not having a certain amount of improvement, that we will no longer continue to recommend the ketamine, because we want to make sure there's some safety in that. And if somebody has a long history of addiction, then typically I would stay away from ketamine, because that can cause more problems than it'll solve.
Thank you. One last one I'm going to sneak in, and then we'll have to call a halt to it. But this goes back to the criteria for TRD, particularly when trying to move to ECT or TMS. And what about the use of a genetic test? I'm assuming, Vilda, you mean for a pharmacogenetic test to help determine the best antidepressant at that stage. Have y'all seen any effectiveness in practice from that?
It's a good question. It's a really exciting topic. Go ahead, Dr. Chatwal.
I was going to say, I'll take a deep breath at the pharmacogenetic testing. Although it has been marketed for a long time, it really is not 100% prime time ready. So the studies around pharmacogenetic testing, and I know people have strong feelings about it, we do offer pharmacogenetic testing. I did that in my private practice if somebody really wanted it, and here, so at the university and here. But typically what we notice is that it's an overly simplified sort of report that's given, where they just give a red, green, yellow. I think it's a good tool in the toolbox to really assess the MTHFR and also look at some specific transporter genetics that can determine what type of medications may be effective and not. So definitely when you're in TRD, you should consider the pharmacogenetic testing. Sometimes I notice clinically that if I get a really detailed history of the type of medications they've tried and what their effects is, that I can typically clinically also assess what would be a good next step. But if it's something a person can afford and they get insurance coverage for, it's definitely a tool in the toolbox. And just to clarify for everybody, the pharmacogenetic testing can tell you what medications you may need to adjust the dosing in, and some in which, because the serotonin transporter is impacted, may not be really great to use serotonergic medications. However, they can't really tell you what medication to pick and which one will be effective. And in terms of most psychiatric medications, we do notice that there has to be a level of trial and error, because each person is unique in terms of how they respond to the medication, what type of side effects they have, what their psychological associations are with the medication. So you have to take that entire complexity in mind. And I will let Dr. Hunter speak to that too.
Yeah, I would just second everything you just mentioned there, Dr. Shotwell. I think they've really taken advantage of a financial opportunity to overstate the benefits in terms of, I'm talking about the manufacturers of these genetic testing. We typically use it for two main reasons at Skyland Trail, one of which is that MTHFR mutation, and seeing if a little bit of methylfolate may really help someone help their other medications work more effectively. The other of which is looking at the cytochrome enzymes in the liver, essentially the enzymes that process most psychiatric medications, and seeing if an adjustment in the dose may be necessary. And it can make a significant difference, certainly. If someone has, under or over metabolized a medication in terms of what dose we expect to work, it can explain side effects that are unexpected at certain low doses, things like that. But, I also noticed a question. I mean, we unfortunately do not have the ability to really effectively use like serum levels, blood levels of antidepressants to measure whether they're effective or not. With the exception of a couple potential uses in like tricyclic antidepressants, we don't measure blood levels because we don't know what they mean in terms of response. We don't have data to support that right now. But I think the best thing to do, I mean, really the most critical data you look at again is family history. So if someone in a patient's family has responded well to an antidepressant, that's usually the first choice we go towards. Second criteria is probably what they can tolerate. So if if they're doing well and they're not having side effects, I'm usually going to stick with that one, raise the dose until I expect it to work, which is often, our biggest issue we see is patients underdosed on antidepressants. That's by far the most common presentation at Skyland Trail in terms of what was previously seen as treatment resistant. Often they just haven't gotten to the doses yet that work disproportionately, which are disproportionately the higher end of the dose range. So yeah, thanks for that question. That's a good one that I think a lot of people have misunderstood over the last few years.
And I think that same question, I was also thinking, I think the individual asked about neurotransmitter levels, and those are typically not what we assess. There are some metabolites that we can assess, but those are, again, not correlated to depression. There's no clear studies to associate them with diagnoses or efficacy. I think the part where I was talking about doing levels was more for nutritional supplementation. So if you're looking at a vitamin D, B12, folate, those are typically like just bottom of the barrel testing that should be done before you're diagnosing somebody with depression. Because if you have a vitamin D deficiency, you're B12 deficient, you have iron deficiency, anemia, you're going to present as depressed clinically, but it really could be that nutritional deficiency driving it. So when you go to a doctor, that should essentially be the first thing that they're doing, along with taking a good history and treating you well.
Thank y'all so much. We are at time, and so I'm going to ask Julie to pop up for our raffle drawing.
Hi again, everyone. So we have 2 drawings left, and the first one is for a Skyland Trail CE Fall Workshop. I'm going to ask Dr. Hunter just to choose a random number between 1 and 167.
Okay. I'll go with my baseball number, 23.
23. Okay, let's see. Lucky number 23 is Demetria Burleson from Texas. Demetria, if you will check the chat, Dawn has put her contact information in the chat, and you can reach out to her for the workshop. And then our second drawing is for Sierra Tucson is providing a Georgia on My Mind gift basket. And I'd like to ask Dr. Chotwell to choose a random number between 1 and 148.
Wow. Let's go with 133.
Okay, let me see here. Hey, lucky number 133 is Valerie Van Dam from Georgia. So Valerie, if you will just message Joy in the chat with the best mailing address, she will get you that Georgia on My Mind gift basket. Thank you so much. And just as a reminder, we're going to move into the coffee chat. So we've wrapped up the presentations for today, and there is information in the chat function for the other Zoom room that Joy sent. So if you'll please access that, if you are one of the 8 winners of the drawing for the coffee chat, we will join you shortly. Thank you.